talking about Prevention Basics 101. First, I just have to go through some continuing ed stuff, which is the fun housekeeping part of every presentation. So this presentation is eligible for 2 hours through the Alabama Board of Social Work and then the National Board for Certified Counselors, and then 2.4 contact hours for the Alabama Board of Nursing. In order to get your certificates, you guys are going to have to complete an evaluation. So the evaluation will be in a SurveyMonkey link, which we'll put in the chat towards the end of the presentation. And then you'll just go to that link, you'll go through the entire evaluation, and then there will be a portion of that evaluation that says, click here if you need continuing education credits. So then you're going to put in if you need credits for the NBCC, for social work credits, or nursing credits. I actually work with the Addiction Prevention Coalition, and we are a very busy but small nonprofit. So it takes about a week to get certificates to you guys. So I always say you'll have your certificates within 7 business days. And so 7 business days from now would be September 19th. So if you do not have a certificate by then, please let me know. But we're always pretty good about getting them out early, but be on the lookout for it. And that's all I really have for that. So I'm going to turn it over to Tasha, who's our presenter for today.
All right.
Tasha, you have the floor.
Thank you. Thank you, Ashley. I am glad to be here with you all to talk a little bit about substance misuse prevention, the basics regarding that. And I know we have a crowd of folks that are coming in to the training on this morning. I'll tell you a little bit about myself as it relates to my work in the field of substance misuse, as well as the organization that I work with. So I work with the organization called She Raising Associates, and She Raising Associates is a not-for-profit, is a for-profit training organization where we provide an array of training to communities from Illinois to Texas to California to Louisiana. So we're in various places. I am in Chicago. So I am in Illinois, and I am a person who have started substance abuse or substance misuse prevention work in 1994. So I have been doing this work for some time now, and I love it. I started as a prevention practitioner or prevention specialist, as they call it, again, in urban community of Chicago. And I worked my way through doing that work from 1994 to being at various other organizations, pretty much too. I'm a person that kind of stick around when it comes to the organizations that I work with. And so throughout that, I went and got my master's in training and instructional design, continued to do coalition community work, and love it. And then throughout that path, I connected with She Raising Associates and TTJ Group, and have been with this organization for about 15 years now, working as what we call an associate, which I do our training. And now throughout that, I have worked my way into being the director of training and design here at this organization. That's me, that's enough. And now I would like for you guys to, and this is, I am going to do my very best at making sure, yeah, that's me, making sure that we are as engaged as possible. And I know that this is a virtual platform and that is almost impossible to do, but I am going to do my very best to make sure that you're engaged, that I give you enough breaks, that I make sure that questions that you put in the chat or the Q&A, that I am gathering those questions. So my virtual housekeeping, I usually go over this when I am not in the webinar format, and the webinar format means that I see you. And so I have, please sign in on your device that records your name. Don't worry about that. Ashley and Olivia, they have that information. We usually share that information because you need to get your certificates, and usually they need to pay attention to who's on and with your time that you've been on. Don't worry about your camera being on because it's just me. You are already on mute, but you will have an opportunity to unmute yourself when you have questions. And so we will make sure that you're able to do that. So I like the fact that someone's chatting with me now. So I appreciate that. And I want to make sure that we all get an opportunity to do that. At the end, as Ashley mentioned, you will get, there will be an evaluation that is very important, because what the evaluation does for us, it allows us to know what are some rooms for improvement that we need to make sure that we're paying attention to for the next time that we do this wonderful thing called training. But also it allows Ashley to know you're here, and that wonderful certificate that you're looking for at the end, she's able to get that for you. And so that's what that online evaluation is going to do for you. So we appreciate if you do that. So now, really quickly, I have this thing that I like to do now in my training. And so now you are welcome to be a part of my new thing that I'm doing in training. A lot of us know that this work that we're doing in prevention, this work that we're doing in communities is heavy, right? It's heavy. And we're trying to make a difference in the world. And today you're here to gain some new information or be refreshed, because I come understanding that some of you, there may be some things that I may share that you know already, right? Or there's some things that you're like, I forgot, I stopped doing that, right? And so you carry all of that with you. And then you come to training and you're distracted and you're not focused and you're multitasking. And I have this belief that multitasking is really not a thing. Now, do I do it? Yes. But I'm telling you, when I do it, I'm really focused on that one thing. We can only really focus on one thing at a time. Something is not going to get your time. Either, that note, that email that you're looking at is going to get all of your time or you're reading, or the training that you're participating in. But I know we try to multitask. But this is what I want you to do. I want you to just, if you could, now, if I could see you, I'll be able to judge that you're doing it, but we're going to operate off the honor system this morning. And I just want you to take a moment, just take a moment, and I want you to breathe in, and I want you to breathe out. I want you to breathe in. I want you to breathe out. I want you to look to the left. Breathe in over there and breathe out. And I want you to look to the right. A couple of seconds over there. Breathe in and breathe out. And I want you to focus back on the screen. I want you to reset your mind on what we're going to do today. Now that we have did a little breathing in and out, I want you to think about your work. I want you to think about what you feel about this work. And I want you to chat with me. How do you feel about the work that you do every morning when you wake up? You decide to put your clothes on. You decide to do everything you need to do to get to either a computer, get in the car, and go in the community to do this work. How do you feel about that work that you do? Why don't you chat that with me so that we can be centered and grounded in what we're doing today? Chat with me. I don't see any chatting yet. I see a Q&A. Thank you. Michelle McGriff raised her hand. You can unmute yourself, Michelle. The chat is disabled. Okay, let me see. Why don't you put it in the Q&A?
Sorry about that. Yeah, I'm not able. Can you hear me now?
I can.
Oh, okay,
can.
wonderful. Yeah, for some reason my chat is disabled and I don't know why.
Okay, I don't know. I'm gonna get Ashley. She's gonna help me out with that. But in the meantime, tell me how you feel. We're chatting now, so you can talk to me.
Okay. Well, I'm just getting started to get out into my community. I'm starting a job on Monday, and I was really looking forward to this session with you and learning new tools and new ways that I can be an asset in my community. I personally am living a life of recovery from addiction myself. I recently took a peer support specialty training and will be moving into that role on Monday.
Okay. Okay. Good.
Really looking forward to that. Thank you so much for
Good.
being here and sharing all of your expertise with us. I really appreciate it.
Yes. Thank you. Thank you so much. Thank you, Michelle. I appreciate that. We're figuring out the chat is disabled. Thanks for chatting and thanks for answering. And I am chatting with folks. Let me see what happens when I chat as well. And I have 2 hands raised. Let's see who's that. Oh, who are my 2 hands? That is Salima. You want to unmute yourself? There you go. Can you unmute yourself, Salima?
Yes, teacher.
There you go. There you go. Tell me, how are you feeling after that? How do you feel about the work that you're charged to do, that you're here to do? Or you raised your hand. I'm not sure why you raised your hand.
Oh, sorry, by mistake, I have raised my hand.
Okay, all right, no problem, no problem. So as we move along, thank you guys for chatting with me, those of you who have chatted with me, but those of you who can see my screen, how about you raise your hand, everyone, if you can, so I'll know that I have hands coming up all over the place. If you can see the screen right now, let me know that I'm all good. I need some thumbs up. I need some reactions so that I know I'm all good, that you guys can see. I see the hands going up. Thank you. Beautiful. Thank you. And so this is me wanting to make sure that we're engaging with each other. So why don't you tell me your name in the chat, answer that for me, or in the Q&A, whichever side of the platform is able for you. And what do you already know about substance abuse prevention? And then what is your expectations of this training? Ashley, you're on screen for a reason. Hey, Ashley.
Yeah. Hey. Okay. So I think I figured it out. Not sure what was wrong with Zoom, but y'all all should be able to use the chat now. Just make sure when you're chatting, you can change it from host and panelist to everyone. So if you want everyone to see your message, of course, you can put everyone. But if you wanted just to come to either me, Tasha, or Olivia, then you can just say host and panelist. But I think we should be up and running now.
Cool. Thank you. Thank you, Ashley. Appreciate that. And then I'm looking in the Q&A, just making sure. Okay, people are talking to me over there. So tell me a little bit about who you are. You guys are chatting with me. Thank you, Michelle. You just chatted with me. You're working in Sacramento. Laura, Durban. Kim, I am recovering addict. Thank you for being here. I raised my daughters to not depend on drugs and alcohol. Thank you for being here. And then let's see who else is chatting with me. Okay, all right, I have more. Oh my goodness, stop Martina. Thank you for putting in parentheses who you are. I do have a degree in chemical dependency counseling and a certificate from CASAC, and I have a lifetime of personal and familiar experience. I don't know we ever know. That's right. We don't know, right? We don't know all the time. We're always working on this thing called substance misuse. And then Elaine is an occupational health nurse and addictions counselor in Vancouver. Thank you. And prevention coordinator with Pride. Kina, thank you. And then Tammy, some expectations, hearing and seeing some information. Thank you for sharing your expectation. And then let me go back to Kina. Your expectation is to receive insight on how your organization might go about prevention in a different way. Okay, hopefully I can do that. I'll share that Substance misuse means use drug despite knowing its effect. Okay. I know prevention is much easier than after detox. Yep, got it. All right. So I'm reading. I just want to make sure. And then Felicia works as a therapist, and Jacqueline supervising clinical team. I see I have a lot of clinicians here, or some. I know I am a learner and will always be. That's right. I love that. Martina. I hope I said that right. All right, I'm going through. The reason why I asked your, thank you all for chatting with me. The reason why I asked for your expectations of the training, couple of reasons. One, I want to make sure that we're on target with each other, that as an adult learner, that's important. I carry that with me. Adult learning, I carry that with me. I have grown-ups on the line here. People come knowing things, and I want to just refresh you. But I have folks here who may be novice in it, but I also want to refresh you, but also give you a nugget of something new and a new perspective. But I also wanted to share with you what I came here to talk to you about. And then we can agree that we're here and we're in the same spot together, and we should be here together, right? So this is the description that I have, is that today, I hope that you will have an understanding of substance abuse prevention being the operative there. What's the history and the methods used to be effective, including understanding risk and protective factors. I really love talking about the risk and protective factors. And I know that no matter where you are in the continuum of health, and we're going to talk about that those risk and protective factors are valuable. And we're sure about that. But I'm also going to talk to you about evidence-based strategies and what we do in the field of prevention regarding that. At the completion of the training, this is what I believe, this is what I hope that you will have, is that we will be able to recall the history of prevention. So we're going to talk a little bit about where this thing came from, when did it start, beyond what people know about Just Say No drugs, but what was the historical path. But we're also going to talk about what are the different approaches in doing substance abuse prevention or misuse prevention. And I apologize because the language is changing. And so sometimes I'll say substance abuse, which is the new language is substance misuse. And I am saying that in the correct way so that as a teacher, a trainer with you, that you can pick up that language for me as well. So the language is substance misuse and not substance abuse. We want to describe the best practices. I am going to highlight for you what we do in the field now that we are growing in the field. We do work as it relates to the strategic prevention framework. And that framework help us in communities and organizations to identify what's going on in the community, but also how to resolve the issues in that community the best way we can. And so we're going to talk about that. And then quickly, we'll talk about your role in prevention, no matter where you are in this work. Prevention specialist, a community worker, a parent, whatever your role, wherever you sit, wherever you posture yourself in the community, what is your role in prevention? So those are the walkaways that I hope that you have after this training. I'm going to pause for a second so that I can go to the chats and see what we have over there. People are chatting with me. They're just telling me who they are, and I want to know. Okay, so that's who I have. And then I have a couple of Q&As. Okay, got it. All right. So as prevention is growing and has grown, I know when I started in prevention, there was this thing or this idea of where CSAP calls Center for Substance Abuse Prevention is CSAP, is the great disconnect. What is that? What is the great disconnect? The great disconnect is this, that over here on one side of the world, if you will, there was research, right? There was things that are being talked about that says, okay, in order to do good prevention work, that the research says you do A, B, and C, and you need to do it this way, right? But then on the other side of the world, you had the practice, you had practitioners, you had people, you had community folks out there doing an array of activities, doing an array of programs, connecting with young people and doing things that will quote unquote prevent them from using or misusing substances. But you can see the divide here, that the science and the practice didn't connect, right? So there was science, but then there was practice and we didn't connect. And what we want to do, this is our vision. This is CSAP's vision for our future. And this is where we have progressed to. I entered into the field, I told you, in 94. And at that time, I was on the other side, right? I was in the community doing the practice part. I knew about research and I understood that there was a reason why I was doing this work, but I was in the very early stages, not quite early, but early enough where doing work in the community, like block clubs and, doing after school programs and not measuring the effectiveness of them, doing things like that was my game. That's what I did. And so we have the connection here. And I'm going to talk to you about how we make these things connect. I'm going to pause for a second if anyone has questions so far. And if Olivia, I know you came off screen, so I wanted to see if you had anything for me.
I actually don't have any Q&As. Sorry, I accidentally talked
Okay.
with the camera.
Okay. All right. I just want to make sure I'm paying attention. My eyeballs are all over the place. So I'm looking at you. So thank you. Thank you, Olivia. So that's the great disconnect. So you'll see periodically where I have like a slide here that just tells you, okay, this is what we're going to talk about now. So I'm going to look at the history of prevention. So I mentioned before that prevention is across the lifespan, right? And so as we work in prevention, we talked a little bit about the fetal alcohol syndrome with infants and its effects on maternal substance use is across the lifespan. So when I talk about prevention, I'm talking about all these areas. I'm talking about children and secondhand smoke and drug being in danger with children and the secondary effects. We're talking about adolescents. We're talking about college age and adults, and we're talking about older adults. As it relates to adolescents, most of my career was on adolescents and that onset and experimentation of drugs, right? Am I looking at delaying that onset, that first time use? But then also, as we understand prevention, it impacts, there's impacts in college age and adults, which is really looking at that progression as they, may have some dependence on those substances. We may not go heavy into that, but rest a little more in the area of what we call primary prevention. And primary prevention being that very first use or non-use at all, like the very first time. And so we were going to talk about that. But prevention also looks at the older adults and the prescription drug misuse or use. And so as I am sharing some of this information, this is who you may be working with. And I want you to see that these strategies that I'm talking about can work across the lifespan. So that's why I shared this information. And yes, you will receive the slides throughout. So let's look at the history of prevention here. So in the 1950s, we had, the situation in the 50s. Now, I did say that historically I had worked on some of the work as it relates to prevention, but I was not around in the 50s. So, but in the 50s, it was the national situation, as you probably remember, you may know, you probably read, was heroin. And because it had heroin issues, the strategy, the simple strategy, the one thing that the prevention practitioners felt like would work was scare tactics and education through films. Now, I know that there are films that had scare tactics in it. Anybody know any films out there that had heroin, people using heroin If you do, chat with me. Did you see those back in the day or early on? Anybody? As you're chatting and thinking, so I can make sure I get through all of this. I know it wasn't in the 50s, of course, but it was placed in the 50s. I believe it was placed in the 50s. But Lady Sing the Blues was a movie that I saw, and you probably saw a newer one where Billy Hop, drugstore cowboys crossing a switchblade, chasing the dragon. Yeah. So they have folks out there using heroin. And they did that, the only strategy was a scare tactic. But there was no research back there in the 50s that supported the fact that that would work. That by itself would work. Actually, we grew up in the field and we learned that, scare tactics alone only scare those who are scared already, right? If I'm a person who is like, I am not using drugs, you showing that to me scares me even more, but it may not scare me in itself to say I'm never going to use. So we grew up. But then in the 60s, the national or the issue was psychedelics. And again, they did scare tactics. And so we're growing up and the history of prevention continue. And this is kind of when I received prevention services. So then in the 70s and the 80s, you start seeing things like alternatives, right? So there was a lot of basketball, sports activities, cheerleading, football. And this is when you hear the main message from our former First Lady, Reagan, just say no. Right. And so that was the 70s and the 80s. And so we're continuing to grow. We're continuing to learn that sometimes these things in themselves are not comprehensive enough in order to prevent or stop or delay the onset of drug misuse. Then we have in the 90s. This is where I really start doing the work. And this is where we start doing more comprehensive approaches. What is a comprehensive approach? Comprehensive approach means that the things that I would like to do in the community, I am going to do them with every sector in the community. What do you think I mean by sectors? Chat with me. What are those? What do I mean by that when I say the sectors in a community? You can guess. I'm going to pause and let you guess for a second and put it in the chat or the Q&A. So that is what we did. Comprehensive work is where we worked in various sectors. What we mean by sectors is you have an individual, right, that's impacted. You have subdivisions, yes, socioeconomic, education, health, economic centers, exactly. So the sectors in a community for you, so I'm in the center. I'm the young person or the individual. So you have the individual, but beyond me, there is a parent or another adult that can impact or influence the message that gets to me. But then comprehensively, those are my peers. So there's messaging that's going out to the peers. Then it grows out a little further. And then it's those institutions like schools that is impacting me. And so services are being offered there. But then beyond that is the community as a whole. And then that is what comprehensive work is in prevention. And so and thank you guys for answering that for those of you who chatted with me. And that was we thought that was it. We're like, this is it. We have done wonderful because we're doing this work in the 90s. Like I said, that is when I start doing this work, and we had to impact all of the sectors. You had to make sure that you were doing parent education programs, that you're doing some things in the school, not just in the school, but about the school. So let me pause there and tell you what we mean by that in the 90s in the comprehensive world. That meant that you were going to work with the schools to help them have policies, right, in the schools that impacted how they approach substance abuse prevention or misuse. And so it wasn't really about because you were in the school, because a lot of people did things in the school because that's where the young people were. It was you do something about the school as it relates to prevention. And then we grew out, like I said. So then when we talk about the community, it's about ordinances, yeah, rules, laws in the community, policies, practices in the community. What's going on? Is your community dry? Or this is in the 90s. So this is when there were a lot of billboards for tobacco, a lot of billboards for alcohol, where young people can see them all the time. And so a prevention practitioner or organization would say, you know what? Part of our comprehensive approach is we're going to go out and we're going to change this so that young people aren't seeing that. So that's comprehensive. But we were only just kind of throwing things out there to see what hit. What could hit. And so 2000 and 2010s is where we understood that there's a connection between substance misuse and mental health. And so the strategy then, as we grew, and this is when I continued to love the field of prevention, is where we had an emphasis on evidence-based programs and environmental strategies. And I talked about that just a second ago when I talked about billboards. So we grew the history, the path of prevention grew where we said, so this is what evidence-based says. Evidence-based practices says that what did the research say in your community? What does the data say? What's the ill? What's going on? What is contributing to this issue? And what's the consumption rate, right? At what level is this happening? But also what's contributing to that? And so let's develop a program, a practice, or policies that will impact that community, right? That's evidence-based. But then environmental strategies is beyond, that's the difference between an individual strategy, because those programs, they impact the individual, right? But policies impact the environment. So policy goes back to what I said about those laws, those ordinances in a community that says this community will be dry, or you cannot have billboards in this community, or the billboards in the community will have messages. That's when you start seeing those commercials that talk about why you shouldn't use, or that was the area where we had different messaging that was just environmental, about changing the environment. How many of you know of any environmental strategy right now that you're like, that just impacted everyone? That message was about everyone. It wasn't necessarily individual strategy. It helped all of us. Give me an example of one that you think based on that example that I gave. Anybody? And it doesn't have to be the 2010s. There's some still out now. Yep, drug-free zones. Yes, exactly. Any other ones? Any other ones? Thank you, Felicia. Drug-free zones near schools. That's an environmental strategy. They changed policy, right? And so I like to talk about this and like to share this because I know when I first entered the field of prevention, it was all about, as a prevention provider, you are going to do a program and you're doing that with an individual, right? But then I help that individual, then they go back into a sick world. They go back into a sick community. So I need to impact the environment as well. Drug watch. Thank you, Kathy. Michelle, harm reduction. Tell me more about that. Chat with me more about that. But Kathy, drug watch areas in neighborhoods. Exactly. What about, forget drugs, drug awareness weeks? Yes, that is, that could be an environmental. Yes, Red Ribbon Week. We're coming up on Red Ribbon Week. That's coming up. That's great. That's an informational strategy. DARE is not necessarily an environmental strategy. Thank you for sharing that. DARE was intended to be an individual strategy, but it is a prevention. It was a prevention program. And so drug take back days. Exactly. Commercials warning about dangers of vaping. Yes, that's an environmental strategy because they're doing, what we call social marketing campaign. It's putting a social message out there about drugs and how to use them, why not to use them, and all of that. Thank you. Great work, you guys. Great work, you guys. And so then we have, this slide talks about, what is prevention really about? It's about encouraging and maintaining health and wellness. It's about helping young people and adults being the best a person can be now, as well as in the future. It's about delaying the onset of negative behaviors and negative consequences and outcomes. Let me pause right there about the delay the onset. When I start doing this work in prevention as well, there was so much research up against what we were doing. Does it really prevent? Do you really have the right program or practice in your communities? And so we would adapt and we would adjust them to be culturally competent, culturally relevant. And I don't mean race, I mean culture. It meant, did that curriculum fit in the community? I say all that to say that as we did that work, the work was really about delaying it, right? The message that I put out there in that time was, I want to delay this. I can't say that you would never, ever pick up a beer, but I want to delay your first use. And so that gave a positive spin in my messaging as well as in the receiver. So when I was in those classrooms and I'm doing that work, I'm like, okay, can I buy time? Can I delay your use until 18? Could I delay your use to legal age of 21? Can we do that? There's some reasoning behind that. And so that would be my messaging. Not that I'm coming in to say, for the rest of your life, say no. But for now, let's delay. And so that was comprehensive work. There was science behind that. So there was an evidence-based approach right there, because I connected the research that said if we delay the onset, if I delay the usage for, a couple of years, then there's a couple of things that we could do here in the medical field, just comprehensively, that people who delay, then they may not have, many medical visits or hospital visits. And so it impacts the community. And so I got people to be on board with that message. And that's the message that I learned in an evidence-based program that I picked up to implement, that we delay the onset. We don't have to talk about you never using, but we talked about delaying the onset. Kathy, how do we get message out about prevention of marijuana use with the legalization in medical marijuana saying it's okay? Yes. When this happened, this is a big issue. We all know that this is a big issue. And when it first became legal, I was like, oh crap, as a prevention professional, right? I was like, oh man, we about to have a problem. But I'll show you some research later, or send that to Ashley to get that to you. It's still about getting that message out about delaying the onset and having a I asked this question of a couple of practitioners at a couple of clinics here in my state. Said, what do we do? It's legal now. What do we like? Man, what are we going to say? And the answer is that, just like Kathy has said, I still see it as a gateway drug, right? And so just like alcohol is the gateway drug, now it's alcohol and marijuana. And so the same messaging that we did when it was alcohol, which was legal, is the same way that we're doing that. And so we're trying to still say we're going to delay your onset of use. I'm using it the same way. I'm saying to you, just like I don't want you to use alcohol at an early age, I'm saying the same thing about marijuana at an early age. I'm saying that I don't want you, to wake up and that is the thing that you have to get to. I'm having that same message. I'm saying, how do you feel when you're doing these things? I'm using all of those messages that I did when I did alcohol, when it was tobacco. So the work doesn't change. They just added a substance. And I just make sure that we cannot ban, we can use, delay the use. Exactly. And it's another thing that I did, and on my break, I'm going to find the acronym, and one of you probably know it. This is one of the things that I use when I wanted to make sure that I'm having, and I'm looking down, I wanted to make sure that I had the right message when I'm having the conversation with young people as it relates to their usage and their, how they want to use drugs. But I just want to make sure that we keep going through the history and all of that. So thank you for all your questions. Is that how you should think with this? That is how, those are the messages, Statina, sorry. If you can unmute yourself and just say your name so that I can make sure that I do not butcher it up. But that's the messaging, yes, that delay the onset, because this is an acronym that the practitioner or the person that I work with, that I went to for advice regarding this, and she's a professional in this field, was you don't worry, you worry, but if you're delaying the onset, you want to make sure that you cage it. And so what is cage? And I am going to say it to you, and you can write this down. And some of you who are in the treatment side of things may be familiar with this. So cage is cut down. If you're working with young people and they have to cage it, which means they're trying to cut down and they're not able to, they have aggressive behavior, which is the A. They have guilt based on their use, or it's an eye opener, which is the E. Eye opener means that they cannot do anything they can't, when they wake up, they have to use the substance, and that being marijuana or alcohol. If you can cage it, then we have an issue. But if you are delaying the onset, then we just want to rest right there. And so that's the message. And I want to get back on track. And I love your questions coming in. So let's continue. Any other questions right there? You missed the G. Okay, I'm going to cage it. Cage is cut down. I'm going to write this in here for you. Aggressive. Well, I'm going to say it because it's going to take me a long time to write it. Cut down. Aggressive behavior is the A. G is guilt. I probably didn't say it. And E is the eye opener, is that you have, when you wake up, you need this. And so I make sure that I tell people about that that the worry is if, there's some aggressive behavior, look for it. If they said they have to cut down, if there's guilt when they say they have to cut down, if it's an eye opener for them, that when they wake up, they have to, then we're at a level beyond prevention, we're in intervention. But other than that, for our prevention professionals, as you are, then we're trying to delay the onset. Kina, I love what you said. The way I go about my lesson with your middle school, high school students, I do deep research and increase their knowledge on drugs. Absolutely, you should. And so instead of just saying no, I'll go with even if you do. So instead of just saying no, I'll go with even if you do them, here's how they impact your brain and your health. And you say a lot. So even if they do them, at least your knowledge is increased. Absolutely, Kina. And that was my area of work as well, where I gave them the information. A lot of young people would always ask me, and I'll tell you two things about that response, Kina, and everyone who's listening. I'll have young people who ask me, well, did you ever use? And my staple answer is, how would my use impact you? How would me telling you that change your behaviors, right? I am here to give you skills, give you knowledge, and give you the information that you need to make your own decision to delay your onset. That was always my answer. So that goes with what Kina is saying. I'm giving you the information so that you can make the decision that you need to make. And I am here to support you in giving you that information. And so that's what I like. Oh, thank you. Thank you, Kina. And so I will always say that, because they will challenge you in those classrooms and they want to know, did you use, and my grandma, used tobacco for 50 years and she's okay. And are you telling me my grandma gonna die? Nope, didn't say that. I'm giving you the facts. I'm giving you the information, and I am letting you make your decision. Please don't go home telling your grandmama that I said that you don't do that. And so I would have to have those conversations. So let me get back on track. Let's look at these approaches that we have tapped into a little bit. And so this is the next objective of this training. So far we have talked about the history, where we've been, and now where we're going. And so where we grew into was different approaches as it relates to substance misuse prevention. So these are some of the approaches and the things that we look at. One, we look at the public health model. We look at the risk and protective factors. We look at the social development model and the resiliency approach, the asset building, which is the 40 developmental assets. And I'm going to show you the categories and then share later with you all of those 40 developmental assets, and then the strategic prevention framework. And so we grew into having various approaches to prevention as we do this work. So these are the elements of effective prevention. So again, as we connected back to the original slide, as we connected the research with the practice, the wonderful things that we like to do in the cheer, rah, after school programs, we connected evidence with them. So elements of effective prevention says there's going to be evidence-based programs, practices, and policies. I talked about that a little bit, and I repeat so that you got it. It focuses on outcomes, but prevention efforts are targeted across multiple domains and are facilitated by the use of environmental strategies. And I talked about that. This is the Institute of Medicine's continuum of care as it relates to how we do the work, right? So some of you, so if you could see on the slide here, you see on the left side, my left side, the prevention. It says universal, selective, and indicated. We're going to talk about that towards the end so that you see all the type of ways that we do prevention, right? I'm going to just touch on it a little bit. So as we do prevention, according to the Institute of Medicine's continuum of care, universal says we do that with everybody. We throw prevention out there and we don't know much about the population and we hope it sticks, right? Based on our research. But then we do prevention and there's a selective approach. Selective means we know a little bit about that population and they have higher risk factors that I'm going to talk about in a second that says, okay, this person is at higher risk and they are all together in a group. They look alike. They seem to be similar to each other. So we're going to do special prevention for them. And then the indicated prevention says that we know exactly what's going on. They may be on the borderline. All of them have things about them that are similar, such as they have a parent who've used substances before and they may be at higher risk. And so we put them all in a group together, or they may be, have high risk as it relates to their truancy issues, as it relates to their behavior. And so they're all in a group together. We know exactly what's going on with them and we're working on them, and that's considered indicated. Okay, so these are the different ways that we do prevention. Then, according to the Institute of Medicine, when we're outside of that realm of what I just described in universal, selective, or indicated, which is going to come back around to you later in this presentation, then we go into treatment. So I want to make sure that my prevention practitioners here understand who you are and where you sit. So you have treatment. And so what I always say to my folks who are doing prevention basics, and this is your first, rodeo at it, we don't do treatment. We refer. We don't go over there and do treatment. because that's not our area. We're here. We're prevention, universal probably, if this is your first time doing this work. Selective probably too. Indicated, maybe depending on the type of organization and what you said that your organization does. And then you go into recovery, which is the maintenance of that treatment, right? So understanding where you are on the institute and the continuum of care is very important as it relates to this work, okay? What questions do you have about that? And then I want to see, as you have questions about that, I want you to look at this image and let me know, what do you see here? What does this image tell you? So I asked you 2 questions. I remember them. 1, what do you see here? And 2, any questions about the previous slide, which is the Institute of Medicine. Chat with me, and then I'm after the 2 images here, I believe you deserve a break. All right, some folks are chatting with me. Oh, that's so good. I definitely get access. Oh, okay, I'm sorry. That's Keena earlier. Carry around a lot of baggage. That's right, Brian. Come on, someone else. What else do you see? There are environmental situations that promote addiction. Kim, you are so right. And that's heavy. That's true. That's what communities are looking like. And that's heavy that we may not be able to even get into a lot of that, but that's so true. How can they focus on learning and positive lifestyle if they can't meet their basic needs? Absolutely. And this is a great illustration of how people feel. Thank you. Systemic and environmental factors that can enable drug use. Absolutely. Absolutely. There's so much going on, right? So this is the part of setting your mind and the pause that I want you to take. That yes, research is telling us a lot. Yes, you're ready to go into that community, that school, that after school program. You're hired to do this work and they say, go in and go do good work. And you're like, yeah, I can do this. But no one is telling us that when I go in and do that evidence-based prevention program that I'm sanctioned to do, that young person that's sitting in front of me is sick, hungry, and homeless. But I'm trying to get them to delay the onset. Yes, and right? Yes, I want to do that. And they have this going on. And so there's a lot that we have to, yes, social determinants of physical health and mental health, stress and fitting in, all of that. So all of that is going on for those students that are in your communities that you're serving. Is this slide to convince you to not do it? Absolutely not. It's to let you know, or to remind you, to refresh you about what you already know is going on. That it's not just about that thing that you're there to do. It's about what else is going on when you're saying this may not be working. No, it will work, but you have to look at some other issues that may be going on. There's another one here. What's here? What's going on here? Same things, right? You have various things going on in your classrooms, in those communities. And you're the one standing there saying, I have to do this program. And you're stoned, you're pregnant, you come from, you're an alcoholic, you got all this stuff going on. And I have this one thing that I have to do. Nope, can't do that. You can't operate in a silo knowing that folks have various things that are going on. Use your research when you're doing your work and understand why you're doing what you're doing and who's in front of you, who's around you, who's in the community that you're serving. So let's look at the public health model. You know what? Before we look at the public health model, like I said, you deserve a break. So why don't we take a 5-minute break? That will get you back to me at 11 o'clock. And then when we come back at 11, we will continue talking more about the public health model and we'll talk about the strategic prevention framework. We're going to talk about risk and protective factors. So go out, get something to drink, and make sure you come back in 5 minutes and we will start there. I will turn my camera. All right. We should be coming back from break now. For those of you who stepped away, I'll give you a second to get on back. We'll start in 10 seconds. We should be back. I can't see you. I'm assuming you're getting back. You have about 5 seconds, just in case you walked away from your computer or start doing something else. Have like 2 seconds. All right, thank you. Thank you for letting me know you're back. Thank you. You guys are wonderful, wonderful virtual participants. I swear, for you to, chat that with me and let me know. I love that. You guys are great. Great, great, great. Thank you. Thank you. Thank you. Thank you. All right. So as it relates to prevention, primary prevention, the basics of prevention, we also look at the public health model. So give me a hand. Show me a hand if you're familiar with the public health model in another world, in another environment that you work in. Let me see hands. I want to see hands going up all over the place. Thank you, Jacqueline. Thank you, thank you, thank you. Thank you, thank you. I see them going up. Thank you so much. So we also use the public health model. We consider the public health model in this work that we do as well in primary prevention, in substance misuse prevention, right? So the public health model simply says this. One, there's a host, right? Which is me. I'm the host. I'm the person that's impacted by, that's going on. So the question in the public health model says, who is likely to be affected by the problem? And so we use the public health model in our research and in our design in this work, right? So I want you to understand that this is important to know. One, because I want you to see that we use different approaches as we combine what we do in prevention to get where we are as it relates to research, but also it helps us to understand the connections with other, if you will, careers, other sectors of the community, as in what I mean by sectors in the community. In that sense, who else in the community understands your work? So other folks understand the public health model, right? And so when we are collaborating, which I'm going to talk to you about a little bit in the end, is that you have other people in other sectors of the community that understands this work just like you, right? So there's a host, that's you, but then there's an agent, right? So that's what causes the problem. So the agent is that substance, right? Substance that we're trying to prevent, whatever that is. That's alcohol, tobacco, marijuana, other drugs, right? And then there's the environment, which is where is this thing happening? The community, right? And we can, boil it down to home, to block. In Chicago, we call it blocks, our community. And so that is what we are looking to remedy in our community, right? We are looking at, hey, what's going on with this host? What is impacting that host? And where is this happening in their environment? And how can I work on this? Thank you so much for you guys chatting with me over there. So let's now look at these other learning objectives, which is I want to look at the strategic prevention framework. Now, the strategic prevention framework, remember, I am talking about the prevention basics. And I just talked to you about the history of prevention and how we use different approaches and what we use in order to do prevention and how do we get here. So after the 2010s, in the 2000s, we grew up and we start using what we call the strategic prevention framework. And this is what we call the flower. Does it not look like a flower? How about, give me hands for those of you who believe it looks like a flower. Yeah, so I don't know what flower, but it looks like a flower. I'm gonna look it up and figure out. Anybody who love flowers, tell me chat with me what flower do you think it looks like? And I'll start using that when I teach this. So it looks like a flower. We affectionately call this the flower. And so I have to tame myself because I love talking about the flower and how the flower, the strategic prevention framework, has guiding us to a better place in our work in prevention, and will get you to a great place as you apply the principles of the SPIF. So the focus of the strategic prevention framework is that on community development and focusing on planning and not just doing things, but also in the change process at a community level instead. Oh, a hibiscus, okay, or a daisy, okay, I love that. And so the strategic prevention framework says that we cannot do this work alone. That is going to be a community level change, right? It's a process for the whole community and not just working in silos to try to make this thing work. And so when we do this work, and I'm gonna come back to this slide because this is where we incorporate in here the principles of the strategic prevention framework, where it also impacts what I just showed you in the public health model. And let me show you that now. So the framework is a planning process. We use data to inform our decisions. It's an outcome-based planning process so that we can have population level change at the consumption and at the consequence level, right? And I talked about that a little earlier. We want to know what are the consequences, what's going on in the community. And what consequences do we see? The data is going to show us that. But also what the consumption rate, how much is this happening? But also the other C that's not here is what I said before, is the contributing factors. The principles of the SPIF are this. It's a continuum. It talks about prevention is prevention, meaning no matter what prevention we're trying to work on. Really, this strategic prevention framework will work on any of the other ills, like violence, substance, like all the other pregnancy prevention. So all the preventions, all the things we're trying to prevent, this process will work with that as well. And so I want you to know that as well. But also successful prevention, it decreases the risk factors that I'm going to talk to you about in a minute, and it enhances the protective factors. What else does the strategic prevention framework does? It requires the adoption of a known effective prevention practice within the framework that works. So it talks about a system approach, right? And then I'm gonna go back and I'm gonna show you the flower again, and we're gonna talk about each step really briefly. It talks about data, the strategic prevention framework. It forces you to look at data across the service systems. And it does that so it can help assess the prevention efficacy and promote accountability at those levels. The strategic prevention framework, it recognizes the importance of states as well as communities working collaboratively. And what the strategic prevention framework, which is what we adopt in this work that we do, is it forces us to do things comprehensively to address the issue. What I would like to do, this was going to be a brain teaser for you before your break, but let me go back because I'm going to skip this. My apologies. Let me talk to you more about the flower. So the strategic prevention framework and everything, every note, every point that I just made leads us back to this, that the strategic prevention framework says that before we do anything in a community, we're working collaboratively and we're doing all of that, but we're assessing what's going on in a community. Remember, I talked to you about finding out what is going on. What do I know? What do I think I know? And what do I need to find out, right? And what do I know? What do I think I know? What do I need to find out? The data needs to speak to my block. The data needs to speak to my community and tell me, hey, what is the drug that's being consumed and what's the rate, right? But also what's contributing to that? Why is that happening? But more so, my data is telling me not consumption, contributing, and then consequence. So when you're assessing what is going on in your community, you're trying to find all that out. Why are you trying to find that out? Because you want to make sure that you're doing the second step in the flower. Is the second step says, now that we know, we need to now build capacity to do this work. But before we build capacity, we need to know, do we have the capacity to do what we know is going on in the community, right? The data says this. Now I want to go out and I want to say the world based on what the data is saying, but you don't have the capacity to do that, right? And so that's when you take a pause and say, okay, wait. We've assessed. We want to see if we could do this, but my capacity isn't built, so I pause. And the work is building my capacity before I plan, which is step number 3. So this is the thing that, and like I said, I love the spiff, because the flower, because it really gets us organized in doing this work that we need to do, right? I assess, I find out what's going on. I assess capacity to see, can I do this? Then I build my capacity. Then I say, okay, now that the capacity is built in my community and the folks who are supposed to be at the table to do this work is here, right? Then we plan. And we plan based on knowing strategically what's really going to impact the issue. What does that mean? That means that when I'm planning, my data said that the issue was about alcohol, right? And so strategically, I am going to plan to do a program, a practice, or try to incorporate policies about alcohol. I'm not going to see that the issue is marijuana and plan to do things about alcohol. I'm going to plan to do things about marijuana because the assessment said that that's the issue, right? But also my capacity said that I have the know-how and the ability to do something about it, right? So your planning has to be strategic and logical. It has to make sense. It points right back up to your assessment. Then I implement. I do the fun part because that's where we all, me too, when I entered into this work of prevention, that's all I wanted to do was implement. Come on, what we doing? Give me the curriculum. Give me that book. Let me go in this classroom. Let me go and do this parent program. Let me talk to the parents. Let me help with this red ribbon week. Let me wrap those red ribbons around the poles. Oh, I want to do that. Great. The implementation is fun, but that's the third step. I got to get there first, but then I evaluate, right? Was I effective? The beauty of the spiff, the flower, is this. In the middle of the spiff is sustaining my efforts and being culturally competent. Why do you think it's in the middle? Chat with me. Chat with me. Why is sustainability and cultural competency in the middle of this hibiscus that I'm going to call it from now on? Why do you think it's in the middle? Yes, Kim, it affects all areas. It is important at all levels. You need to do it every time. So if I had to rewind, I would say when I'm assessing, I'm making sure that that's the assessment process or whatever I do there, I'm sustaining that and I'm making sure that it's culturally competent, right? That my assessment that I'm doing, that I'm making sure that that I'm asking the right questions, and I'm also making sure that I'm asking the right people. I'm also making sure that it is linguistically appropriate for my community, right? So I'm being culturally competent, but I'm also sustaining my efforts. Also, capacity. I'm sustaining and I'm being culturally competent as I go. So all of this is as I go. I'm not doing this at the end. I'm planning. As I'm planning, I'm making sure that planning process is sustained and is culturally competent. When I'm implementing, I'm making sure it's sustained and culturally competent. I'm evaluating and I'm doing all of that across. What else is great about this flower? Tell me about this hibiscus. Why do you think it's a flower and not a line? Why do you think it was a flower and not a ladder? Chat with me. Why do you think that was so? CSAP did a wonderful job at this. So why do you think it's a flower and not a ladder? Yep. You never reach the end. It's cyclical. Change of season and people. Prevention is a constant cycle. Absolutely. When I'm at planning and I mess around and I'm over here in planning and I figure out that this is not logical anymore, we can't do this program, practice, or policy that we said we wanted to do now that we're at the table to plan, because now we got other folks here at the table with us. We got to go back up to capacity. If I was on a ladder, if it was an image of a ladder or a line, then I am prone to just keep going. I'm just going to do it wrong because I'm down there. I'm down there on the ladder, or I'm down there on the line. I'm not willing to go back up, right? But if the circle says it's a circle, so go back. Go back. I'm at capacity and I need to find out a little more about this community. Let me go back to assessment. Also, the circle says, even though evaluation is on the end, that's the main evaluation, that's the outcome evaluation. At every level, I'm evaluating, right? So, I would add piece, I would put evaluation in the middle as well. I do that when I talk about this fully. So just to let you know, this right here, strategic prevention framework, is a training in itself. And so, I'm just kind of touching on it. We teach on every area of the strategic prevention framework, and maybe later we'll have an opportunity to talk about that more. But the point to this training as it relates to prevention basics is this is where we are now as we do this work in prevention. We're at the strategic prevention framework level where we're assessing, building capacity, planning it out meaning now selecting what you're going to do, right? Implementing that with fidelity, meaning you're going to implement it the way that it was designed to implement, and then you're going to evaluate it. So this is what prevention is all about. It is knowing, understanding, and applying the strategic prevention framework to go out and do your work in the community. Let me get to my slide that I wanted to. Again, let me pause to let you know that that was going to be your break, but you took it already. We will have the PowerPoint slides for you. Ashley will make sure that everyone who has participated in training on today will receive these slides. So no fear in that. So you will have this information and any other. I have 2 documents that I do want to share, this being one of them, the asset approach. So we have the strategic prevention framework, but also as we do prevention, and the reason why the asset approach in doing the 40 developmental assets came before we start doing the strategic prevention framework. However, this is something that I put it here because I don't want you to think that the asset approach doesn't fit into the strategic prevention framework. It fits when you're implementing, right? So I want you to know that. And so we look at the assets, the framework there in prevention is the 40 developmental asset. It's based on research done that says, we're going to look at the positive. We're going to look at what are the assets in young people and build on those as we implement in order for us to prevent the misuse. And these are some things about the developmental asset framework. It emphasizes on the strengths, as I just said. It focuses on youth as a resource, but not a problem. And the reason why, again, I repeat myself, we talk about this now is because we talked about SPIF, we talked about implementation. It focuses on increasing the number of assets that are present in a young person's lives. And it's basically a promising framework. These are the categories. what I will share with Ashley to share with you is in each category, there's themes within the 40 development assets, hence 40. So there are 40 things. So the categories though, when you're working on that model in prevention, is that you are going to support individuals as they do this work. You're going to find in your implementation of your program, practice, or policy support. How do you do that? You're going to find ways to empower, because the research with the 40 developmental assets says that that research supports that empowerment. Then you're going to talk about boundaries and expectations. How do you do that in your implementation? Constructive use of time. How are you going to incorporate that? Am I saying you have to do all of these things? Absolutely not. That's going to be almost impossible. It's 40 of them. But based on your research is going to show you, and then I'm going to show you the risk and protective factors. Your research is going to show you in what areas are the gaps of where you can, try to build on. Commitment to learning. If you find in your research that research is saying that young people are not really focused on their education, which is then in turn, which could be a contributing factor, right? Which is then making them focus on substance misuse, then you may say, you know what, we're gonna, focus our implementation a little bit here, or find a curriculum, an evidence-based curriculum that supports that, right? Positive values, social competency, and positive identity are the 40 developmental assets. Let me pause. Yep, okay. How can I watch the rest of the recording? Ashley will chat with you about that later, or we'll chat with you, Kathy, regarding that question. So we have the 40 developmental assets. And again, these are all different approaches in prevention that they work together, not against each other, okay? Then you have the social development strategy, which is, it takes us to the key protective factors, which we'll talk about in a minute. And I want to go straight to the protective factors, the risk and protective factors here. So this all goes together. Let me go back. I don't want you to think I rushed past that. The social development model takes us to our risk and protective factors, which are right here. Remember earlier, I talked about the sectors, not just the sectors, but really the domains. The domains, really, that's a better description of it, is the domains, the sectors being the communities and all of those areas that influence a community. But the domains are these. So you have an individual and a peer, you have the family, the individual, then you have the peer that impacts them, then you have the family, the school, and the community. So the risk and protective factor says, what are the risks at all of these levels? What are they? And you'll see on this image that there are some risk and there are some protective factors. So the opposite of the risk factor is the protective factor. The protective factor says, what are those things that are keeping that young person together? So what is present in the community as it relates to their peers, their family, and their school, and the community as a whole that protects? So I'll ask you that question. Think about your block, your community, where you grew up. You use or didn't use, who knows who's discussing that, and we're not. But as it relates to your childhood, what were your protective factors? What was around you that you feel like that was a protective factor for me? There were risk factors around me, but there are some protective factors that also were around me. Chat with me about that, and then we'll talk more about the risk and protective factors. Yeah. Yep. Yes, Boys and Girls Club, stable home life, my Nana, absolutely Nana. Absolutely, absolutely. Things like that, stable support and family, right? All of that, and you guys are continuing to chat, everyone can see. So there are things that the church, absolutely, neighborhoods and church. So there are things that counter these risk factors. Risk factors, and there's list of them. Risk factors are things like, unstable neighborhood, the school not being supportive. So risk factors are predictive of higher levels of adolescent substance abuse, delinquency, teen pregnancy, school dropout, and violence, right? And so there's a list of them, and I'm going to share that document with you. So you're going to get 3 things from me, right? And so risk factors these are like categories that I'm sharing with you now. So availability of drugs is a community risk factor. Availability of firearms, community laws and norms that are favorable towards that, right? Media and portrayals of violence, transitions and mobility. I move around a lot, right? Low neighborhood attachment, extreme economic deprivation. Those are risk factors in a community. Then here's others, community risk factors, community laws and norms, extreme deprivation. And I repeat myself, that's a double slide. Adolescent problem behaviors is another risk factor, but it's in the school sector. Academic failure, beginning in late elementary school, and lack of commitment to school. That's a risk factor. Then we want to bump up against that with a protective factor. So risk and protective factors exist in multiple contexts because people have relationships within their communities and larger society. Each person's biological and psychological characteristics, they also exist in these multiple contexts. So basically targeting only one context when addressing a person's risk or protective factor is unlikely to be successful because people don't exist in isolation. So that takes me back to our history that says, remember I said the DARE program or don't say no to drugs and all of that Reagan did, or say no to drugs. And that was the thing to do. That in isolate by itself only focused in on one risk factor and probably was one comprehensive factor. That is why doing comprehensive work is what we aim to do. And that is what the SPIF teaches us to do, that we say, okay, what are all the things that we can do? How can we do this comprehensively? And how can we get other folks in different sectors to help us do this work? This is also images or conversation about the risk and protective factor. People with some risk have a greater chance of experiencing even more risk factors, and they are less likely to have protective factors. So when you're doing your assessment, you're finding that out. Young people with multiple risk factors have a greater likelihood of developing a condition that impacts their physical or mental health. Young people with multiple protective factors are at a reduced risk. What does that mean for us? That means for us that we're going to build on these protective factors, right? We're trying to build them into our program models. We're trying to make sure that they're aligned. These correlations underscore the importance of early intervention and then also interventions that target multiple but not single factors, as I talked about previously. And this is more about risk and protective factors. They can be associated with multiple outcomes. Negative life events are associated with substance use as well as anxiety. And then prevention efforts targeting a set of risk or protective factors have the potential to produce positive effects in multiple areas. Now, one of the things that I didn't share, and this is more about the risk and protective factors, but let me pause to say what I was going to say. As we talked about risk and protective factor, I can't help, which I didn't add here, but I will send it again. That's another thing that I would like to share with you. And some of you may know what this is ACEs. Don't forget about that. And ACEs is, I'll tell you what it is, and it's spelled ACE, apostrophe S. Adverse childhood experiences, right? Don't forget about, and then you have a pair of ACEs. So ACEs is a list of things that happens to young people that put them also at risk. So ACEs says that if there's poverty, right, like what we're talking about now, what you see on the screen here, it talks about things that are in my home, like abuse, which is my adverse childhood experience. So don't forget about ACEs. And like I said, I'll share them. But then also when we think about pair of ACEs, as they term it now, is not only what went on in my home, but what's up with my community. What's going on out there is a pair of ACEs that speaks to how I'm impacted, what risks are going on, and why I pull, I am gravitated towards substance misuse. And so it talks about that. And I want you to have that in your bag of tricks, in your back pocket, to understand that information. Yes, Meredith, I agree. The pair of ACEs or ACEs is so important, and I'm going to share that. And as a matter of fact, I'm going to start sharing that directly on this slide when we talk about risk and protective factors, because we're talking about the same thing. That's the beauty of research, right? It's all titled different, in a different way, but it boils down to the same thing. What's going on with the youth? What went on in the community? What's putting them at risk? Do they have multiple risk factors, and what can we do about it? No matter what the title of the research is, it's boiling down to the same thing. And what we're saying is we're raising our hand and we're saying, I want to know about this because I want to help. I want to do something about it, right? And then the resiliency approach, which is what we're talking about, protect risk and protective factors, says that based on that concept, that there are protective factors, which are in my personal, my social, my familiar, and my institutional safety nets. How can we help in that area as we do this work? Which, what it does, the resiliency approach, it enables individuals to maintain competent functioning in the face of major life stressors. We are helping to build young people's capacity to be able to have the answer about the issue that may be going on, the issue of how to say no to drugs. We're giving them the resources, we're giving them the capacity, but also we're hopefully building a structure around them that is not so hard to say no because my environment looks okay, where it's not prevalent in my community. And individuals' resiliency at any moment is calculated by the ratio, just said that, between the presence of protective factors and the presence of hazardous circumstances. So what's up? Do I have more resiliency or more protective factors than I have risk factors? And what are we doing to protect? What are we doing to build the gate around them, building a fence around them? So the resiliency approach, as with the 40 developmental asset, says we should, when we go back to the SPIF and we're at implementation, we should look at these things. We should look at adventure and learning. We should look at arts-based learning, service learning, cooperative learning, project-based learning, and mentoring and peer helping, says the resiliency approach, as we're talking about various approaches to do substance misuse prevention work. Then we do it at these different levels, which we call prevention interventions, which I talked about earlier. So everything that I've said and all the different approaches that you can do this work in using, like I said, your guide of the strategic prevention framework, is your intervention level is going to be either universal, which are activities that are designed for the entire population, or selective, is, subgroups at a general population that are at, higher risk of substance abuse, right? They're like those pullouts. Being indicated, these are young people or individuals who are experiencing early signs of substance use, right? So the difference between selective is that the selective group, they're a subgroup that it says, okay, that group right there is more at risk, but they may not have any early indications of use. Indicated says they have experienced a little bit or they have early signs of substance misuse. And these are the different interventions of substance misuse prevention work. And we do them at these different levels. And this is what CSAP says are also our different strategies that we can do them at. One, we do things like information dissemination. All of this is comprehensive work, right? So we can say, you know what, I'm going to pass out brochures. I'm going to pass out some information so that people know that. You all have probably done that. Know people who have done that. Good. That's great. We keep going. And that's one of the strategies that CSAP mentions. The other strategy that you can do this work at is community-based process, which that process says that you want to enhance the ability of the community to impact what's going on in their own community. So you're going to build a coalition, you're going to have collaborations, you're going to have networks that are focused in on that issue, right? So you can pass out information, check mark, you have done prevention work. You want to do a little more, you may say, you know what, another strategy is to build the community where we're building coalitions and networks. And I'm going to talk to you about that in a minute. And that is called community-based process. A lot of you talked about education. So you're probably doing some of that work. I did it. That was my introduction to this field. It was information dissemination and education. Then I started doing some community-based processes. Education says you're in a room with young people, 25, 30 of them, 50, whatever the number, and you're educating them about the ills of substance misuse. That's another strategy. Another is activities, right? Where you're giving them alternative activities in order to do this type of work, and you or to give them another thing to do in the community, like basketball, cheering that we talked about that we did in the 90s. We didn't erase it. We just made sure that we make sure those things are comprehensive. And then the last strategy that CSAP talks about, again, CSAP being the center of substance abuse prevention, is problem identification and referral. This is when we find out that those who are using alcohol, tobacco, other drugs that is beyond what you are doing in prevention, and you are referring them. Remember the slide that I shared with you about the continuum of care? That is where you connect the dots with your friends in the community and say, okay, this is going on over here. I'm trying to do substance abuse prevention, not what I should be doing. They've been in my classroom. I've educated on the issues. I've given them some activities, but you know what? This may be what's better suited, right? Everyone may not be at that level. They can come back your way, but you refer them out so they can get the proper service beyond your primary prevention work. Okay, so that's the strategies of prevention. However, is that we know how to do problem identification and referral. As I go to lean into a close, not at a close, but lean into it, I want to talk to you about coalitions. And I want to talk to you about coalitions because we talked about comprehensive strategies. And as we do this work, it's not only about you doing it alone. It's about working with a coalition. I call them COGs. If you notice, I have a lot of acronyms that I work with. So COG is a coalition, organization, or group, but the C part is coalition. So it's different folks coming together saying we're going to work together on the same mission, right? And that mission, since we're here together, is about substance misuse prevention. So we're coming together. I'm grabbing all the sectors. I believe it's 12 sectors in communities. So I'm grabbing all of these sectors and I'm working with them together in order to do this work. As a matter of fact, there they go. So we're working together at the level that we can work. So you have, good, Meredith. You love working for prevention, and prevention coalition is amazing that we can accomplish what we can accomplish together. Absolutely. So these are the sectors that as you do your work. Now, I said a lot and now I'm saying more. I told you, you need to make sure that you do your assessments. I told you that you need to build capacity. I've told you in prevention, you need to make sure that you understand the different interventions. Is it is it in universal? Is it indicated? Is it selective? I said a lot, right? But all of that is true to a prevention baby, a prevention practitioner. I say prevention baby because these are the things you learn early on, but these are the things that you keep learning and getting better at every level in this work of prevention. Why is this important? It's because although I'm telling you that you're to know all of these things, I'm also telling you that you shouldn't do it alone, that you do the work that I told you to assess, to build capacity. You do it with these friends right here in different sectors. Will all these folks be at the table? Nope. Should you invite all of them? Yes. Should you be on one accord with what you believe is the issue in the community? Hopefully. Do you have to do that work? Is that a work within itself? Absolutely. That when we're talking about the step of capacity in prevention, we're also talking about building the capacity and assessing the readiness of your community sectors to even do what we said we found out was an issue in the community, right? We said, okay, this is the issue in the community. You went to your different sectors. They don't agree. So now you got to come back and assess their readiness to do the work. But these are the sectors that you want to work in with in your coalition work. I also like to introduce this now because that was something that as I started doing prevention as a prevention basic is that I learned about coalition and networking later. Didn't know that these were my friends. Didn't know that I should be working with them. So I think it's important for you to know now that, you know, this should be in your bag of tricks. This should be in your back pocket on how are you building your understanding of the coalitions or building a coalition, being a part of a coalition where you can do the work that you found out that is an issue in your community and you're not doing it alone. Everybody grab that. You're going to have this slide and you're going to see what we mean about the sectors. And this is who you're working with. So this is what a coalition is. This is all, I'm gonna put it all up so it doesn't slide in. Oh, sorry. So what is the difference? We talked about programs. It's for participants. That's a program. It usually focuses on individual factors. It targets the outcomes for a participant, limited to activities to address policy change. If you're finding that the issue is an individual thing, you go in and you do an individual strategy, great program. But you find out that these individuals you're working with, they go into a sick community policy. That's coalition work. It's responsible for all the members of the community. It's most effective when it is focusing on environmental factors, which is policy, which is billboards, and it's targeted at the community level and the strong role in affecting policy change. That's that shoulder tap stuff. That's what I mean by shoulder tap. That is a policy about alcohol, where young people are able to buy alcohol in communities by doing what they call shoulder tap. They tap on the shoulder of an adult who says, yeah, I'll buy it for you. Well, you see that happening. Your assessment says that is how young people are getting alcohol. Then you work on policy work while you're working on a program that is a life skills program that is helping that individual. So you couple, right? You do yes and. You do it all if you can, okay? Then the coalition, this is what a coalition is not. It is not a human service organization. So it's not your organization saying that you're a coalition. It is not a prevention program. It is not externally run or externally driven by by an organization. It is not an automatic link to your grassroots organization. And so it is not a quick fix. But what it is and what it does, it affects the entire social environment. It develops a broad base of support and teamwork. It brings results that are long lasting, because when you leave your program, I know you guys aren't leaving, you're going to stay, but just say you win the lottery and you're like, man, I love this work, but I'm gone. Then that coalition continues to do that work. It brings results that are long lasting, as we just said. So this is where you focus in. So strategies targeting programs are these. This is that sphere. And then strategies targeting coalitions are norms, regulations, and availability of substances. Again, when you assess and you find what is really contributing to the issue, and it's about regulations and the norms in the community and the availability of that substance in the community, that's coalition work. When you say the young person just does not have the skill and we need to help them, the school needs to have some policies about that, that's strategies, that's your program work. So these are the distinctions of when you use a coalition or when you use your organization and how that impacts and influence. What questions do you have about that? We have about 15 minutes. I want to pause for questions before I close. I'm not at a close, but I'm inching towards that. And I want to see how you guys are feeling. This is an opportunity for questions, observations, or thoughts, either in the chat or in the Q&A. All right, nothing. All right, I'm gonna force you at the end. So this is just an image that talks about the power and partnership. Don't be flying, service silo. Don't just do it alone. This one last slide, talks a little bit about, it takes us back to planning, okay? Thank you. It takes us back to planning. So in the planning phase of the SPIF, I talked about evidence-based prevention programs. So let's pause for programs. Evidence-based prevention programs, there's a federal registry that allows you to go into that federal registry to say, okay, this is the demographics of my community, right? And this is a list of them. SAMHSA has one as well. I'll share that with you too. You type in the factors that are going on in your community after you've done your research and you're at the planning phase, and it populates for you all these wonderful programs that you can select, and you select them, right? And you say that one right there, based on everything, my demographics and everything that is going on, based on the risk factors, based on the research. This is what's going on. And it populates for you the programs that you could use. And so I share with you this, that you're not out there alone trying to figure out what to do in prevention. There's all types of resources and federal registries, like through SAMHSA, which I will share with you, with Ashley, who will share with you. Actually, the federal registry is a little different now, but there are peer-reviewed journals and different pieces that you can find out what program, evidence-based program that I told you earlier that is effective, right? That we want to use an evidence-based program in order to do our work. And you go to that registry and it gives you this wonderful list of what you should be able to do in your community based on your research. Last thing I want to say about evidence-based prevention strategies, there are things out there called promising practices too. A promising practice is the research hasn't been supported exclusively by the federal registries or SAMHSA, but they're promising, they're getting there. So those are the type of programs that you can identify with as well. And the CDC has those as well, as I have listed here. Lastly, you all may have what I call a standards-based program. What is standards-based? Standards-based is a homegrown program that you didn't find anything that was culturally relevant, maybe, that really spoke to what you saw the issue. And so you developed a program that you felt like would be best. Or you took a curriculum and you pulled from it, adapted, adjusted, and did all that wonderful stuff to it. Even a standards-based program, you still have to follow fidelity. You have to do what you said you would do all the way to the point of you evaluating to make sure. So you want to make sure that you do all of those things. as you do your program. Now, as we're at our close, I want to do what I call a closing whip. The best way for us to do that is in the chat. Or, yep, let's use the chat. And I want to know how you feel about all of the information that I've shared in this hour and 50 minutes. What did you learn? No. And so let me tell you about a closing whip. The closing whip is the closing, and it's you're whipping around. It is about 50 of us left, and you're only choosing one sentence stub. I have to always say that you don't have to choose all of them. I just want you to choose one. And I want you to say, what did you learn? What are you hoping for? Or what do you want to know more about? Or you was disappointed that hopefully there was nothing, but maybe there is. And I discovered that. So we're at our close. Now, if there's anyone who's brave enough and want to get off mute and share verbally, we can do that as well. Ashley or Olivia, I don't know how to monitor that based on seeing who's going off the mute to make sure that they're not talking over each other. If we can do that, that would be great for those who would like to talk. But for those of you who would like to chat, I would love to get at least 40 folks chatting with me. If not 50, 40 people letting me know what you like, what you learn, what you hope that, what do you want to know about? I take that seriously because then I'll email it to you. And disappointed or discovered that, I am taking out my pad so I can write down things that you want to know more about so that I can possibly send it to you. This is my commitment. I said that I was going to send you this PowerPoint. You will get that. I said that I would send you the 40 developmental assets. You will get that. I said that I was going to send you the risk and protective factors. I'm writing that down because my brain is not as young as it used to be. So I got to write it down, risk and protective factors. And I said that I would send you the information for the registry about selecting programs. It is becoming extinct. They're changing it, but I'll send you what they have, registry for programs. So I have those things that I'll send to Ashley, who will make sure you wonderful people receive that. I have 9 folks chatting with me. I would love to see 40, but Ashley, Olivia, did anyone say they wanted to chat? Wanted to unmute themselves?
I don't see anyone, but if they want to raise their hand, then we can hit allow to talk. And
Yeah.
also I'll save the chat and I'll send it to you as well so you can read through all the feedback.
Thank you. That's gonna be great because I was about to take notes, like what do they want to know more about? I love that, Ashley. I appreciate you so much. Okay, I'm reading very good information. Thank you guys for your okay. So whatever you send, Ashley's gonna send me the chat. I will make sure I get what I have to share with you. So I'll make sure you get the information. Okay.
Yeah, and I just dropped the evaluation link in the chat and I'll put it in there a couple more times so it doesn't get lost as people are starting to sign off. But if you will go through that and fill out the evaluation, and also if you need continuing education credits, be sure to select the other link at the end of the survey and it'll give you an opportunity just to say like what credits you need and then put in your license number. And like I said at the beginning, we hope to have certificates to you guys by September 19th. So be on the lookout for those.
Thank you. And I'll stay on because I did surprisingly I'll stay on because I know we need to stay on for our time. I'm here for the next 6 minutes. If you have any questions for me, I am still here. So you can unmute yourself, raise your hand and unmute because I can share. And Ashley, I see folks saying they don't see the link. Ashley is resending the link as you go because it goes away after a while. Oh yeah, we do a presentation on implementation of various programs, Felicia, so we can probably share some information with you about that. Thank you, Ashley, for sharing the link. Any other questions for me? I would love to take those now. And I'm steady, I'm reading. Yes, we will get the slides. Thank you. everyone will get the slides. And I'll stay on. I'll be here for any questions.
All right. Well, thank you so much for doing this. It's super helpful. This is a topic that you could speak about for hours because there's so much stuff that goes into prevention.
Yeah, yeah.
But good job condensing it down to just 2. So.
You are very welcome. And that's our contact information if folks wanted to reach us beyond this, but I know, Ashley, they can reach you and you can get to Olivia, who can get to me, but I have your email now, so you can get to me. You can get to me. Again, I'll send all of this to you you'll get it today. Let's just say that. You'll make sure you have that today. And Ashley, when you send me email me again the information that I need to send to you about what we talked about previous. Okay, yeah, if you could email me that would be great. I appreciate it. And like I said, I'm gonna stay on till everyone hops off.
Also, shout out for being able to engage people on a virtual platform. That's very hard to do. So good job.
Yes, it is. It is. Thank you. Thank
I
you.
was thinking that too. I was like, how is she monitoring chat and talking? How the heck? I cannot do that. So kudos to you.
Thank you. I think I've lost my voice today though. That hasn't happened in a long time because usually we're able to let them talk more in this format because there's so many people. I love that it was well attended. I know, we had a lot of people register, but we had 54. So with you guys, what, 50? Yeah, about 54. That's awesome. And I'm so glad to get this information out to 54 people, 50. I really am. So yeah, I love this work. And as you can tell, I can talk about it forever. I really, really can. I really can, especially the spiff. I go on and on about that because I love it. It's a great model. So, but so there's no, I'm gonna stay on because I know we need to stay, or do we need to stay, Ashley, for people to they get their CEUs?
We don't actually have to stay. I'm gonna leave the evaluation link in the chat.